I want to welcome everyone to today's session on antibiotic use and resistant tracking and reporting. This is a very vital part of your antibiotic stewardship program. You want to always understand what you're doing. You're doing this great program of restricting antibiotics throughout your system and making sure that they're being used appropriately. And the only way you can really decide that is monitor and track it. So that's really one of the key purposes of today's session. I want to welcome both Minnesota and Ohio HIND participants to this program. So next slide. I want to remind everyone the link for today's evaluation it's in your invite to this meeting as well, but it's on SurveyMonkey and the link is here as well displayed. And I just want to make sure I remind everyone to access this link and complete your evaluation, and it'll remain open for 2 weeks. So being the 10th today, it'll close on the 24th. So just be aware that you do need to get these done within the next 2 weeks if you are interested in credit. We are providing both nursing and pharmacy credits. So if you're a pharmacist, make sure that you include in your, when you do your evaluation, your pharmacy number so that we can give you credit. And if you have any questions, feel free to contact Dorothy Aldrich. Her email is here. And we are no longer doing the fax, so if you were used to that in the past, so we are encouraging everyone to do it online so you can get credit. With that, we'll, and the other thing I would like to remind everyone is we will do the question and answer at the end of the session. Please put in any questions that you have throughout the presentation in either the QA or chat box, and then we will address those at the end of the session. That way you'll be sure to get your questions answered. With that, I would like to introduce today's speakers. First off, from Premier Health System, we have Craid Pleiman. He's a PharmD, and his role is antibiotic stewardship for the system. He got his bachelor's in pharmacy from the University of Toledo and his PharmD from the University of Florida. He started antimicrobial stewardship at Miami Valley in Dayton in 2000, and then formed the Premier Antibiotic Steward Subcommittee of the P&T Committee in 2014, and did a formal IT support. And he continues to facilitate this subcommittee on day-to-day basis on antibiotic stewardship at Miami Valley. With Craig, he has Christopher Connelly, and he's the Senior Data Analyst at Premier Health Quality Analytics, doing quality data collection and analyst and consultation. He's and he has his Master's of Science in Engineering from Wright State University. So I welcome both of those. And then after Craig and Chris present, Pam Swarny from Union Hospital in Dover will present. Pam is the Director of Pharmacy at Union Hospital. She had her Bachelor's of Pharmacy from and PharmD from Ohio Northern University, and her JD from the University of Akron School of Law. With that, I want to go ahead and hand this off to Craig for presentation. Craig.
Thank you. So we're just going to roll through a little bit of kind of the brief history of kind of where we came from and what we've done and kind of where we're at. So with that, we can probably go to the next slide. Premier Health is a 4-hospital network or health hospital system over here in Southwest Ohio. Relatively diverse group of hospitals, everything from a large 800-bed Level 1 trauma center, which is where I'm at here at Miami Valley, to small community hospitals such as Upper Valley Medical Center in Troy, which I think has about 140 beds. So much of what we've done as a system has, or in terms of antimicrobial stewardship, has been done as a system, but there's also some site-specific metrics and initiatives that we've run as well. So I guess next slide. So in terms of background, as you alluded to, I was kind of moved into a role with infectious diseases back in 2010. That was prior to us having any kind of formal stewardship program in place. We actually initiated a pilot program here at MVH with a new CMO that came to our healthcare system with a formal infectious disease background. And she had a lot of experience in terms of antimicrobial stewardship and a lot of experience with the CDC as well. So she was really a predominant driver in getting things up and off the ground. So we piloted a program back in 2014, and that 6-month pilot, the data that we were able to generate out of that pilot program was utilized to implement stewardship at our other sister hospitals as well. So we have about 2.5 formal pharmacist FTEs, and then we also have paid physician support at each of the 4 hospitals, which we'll talk a little bit more about moving forward. Since that initiation of that pilot program and then expansion to the other sites as well, we really run most of our initiatives through our Antimicrobial subcommittee, which is a subcommittee of our Pharmacy and Therapeutics Committee. We meet monthly. It's a pretty well attended committee in terms of infectious disease physicians and pharmacists from each site. But we also have our quality folks in infection control, microbiology, and we even have branched out now and have some family practice physician support as well. So we continue to bring new players on as our stewardship initiatives continue to evolve. Next slide. So yeah, functions of that committee, are kind of listed there. We certainly do lots of formulary review of antimicrobials along with kind of implementation of best practices, lots of MUEs, so medication use evaluations, along with specific disease state treatment reviews. Not the last thing that we kind of do that's not really touched on in here is that we actually develop and kind of have, so when we first started this, we've had to develop metrics by which to measure our performance, which has been kind of a difficult process, but that's also another thing that we do through Antimicrobial Subcommittee, and we'll kind of circle back to that in upcoming slides. So next slide. What we do measure through our ID Subcommittee, like I said, we do that at a system level. It gets reported up to our Pharmacy and Therapeutics Committee, which is also at a system level. Currently, our medical executive committees are still site-specific, so the data from our P&T goes back to our med exec committees and then up through our board of directors at each site. We recently had our joint commission survey just a couple weeks ago, and this was something they asked us specifically about was, where does your stewardship data go? Like, what's your reporting process? How does it get disseminated to medical staff? So this was something that was good to have in place, a formal reporting structure. It certainly answered the question very pointedly at that time. So next slide. So back when we started this, we were kind of told we had to measure something, which is really kind of where the rubber meets the road in terms of antimicrobial stewardship. And it's not just that you have to measure something, but frequently we need baseline data, right? So we don't even need to know just what we're doing moving forward, but we need to know where we started from. And we're just kind of starting in terms of like formal metrics in terms of antimicrobial stewardship. There's nothing formal out there. So as we talk through these things, like we like to pick something that we're already measuring. So whether that be through the quality departments and looking at things like contributions to our sepsis measures, whether that be through the old SKIP initiative where we had lots of formal monitoring that went on previously. We've flipped in terms of that a little bit moving forward. We don't have to devote those resources to it. Just kind of knowing where your problems are can help you kind of determine what measurements you need moving forward. One thing that we've been able to do here from the get-go, originally, and I still do some of it, is we actually have calculated days of therapy per 1,000 patient days. So back in 2014, when we were initiating our stewardship pilot, based on recommendations from the CDC and what was out there from IDSA and some other organizations, kind of the writing was on the wall in terms of days of therapy per 1,000 patient days was what was going to be looked at moving forward. So we determined at that time to kind of do our best to extract what we could and measure that from the get-go. So we were doing this manually, and we started with select antibiotics, which are listed there, but a lot of our commonly used broad-spectrum gram-negative drugs, along with some MRSA therapies, carbapenems, et cetera. And honestly, our metrics over these last couple of years have included goals of decreasing days of therapy. So our baseline data that we were able to generate back then has been utilized to kind of measure where we've come and where we're heading since then. So next slide. This is just a graph of some of that data. So this is our inpatient days of therapy per 1,000 patient days that we've been able to measure. This is not out of NHSN yet. This is what we've done manually. We started our this graph actually represents a cumulative number of all those days of therapy of each of those drugs that was listed on the previous slide. And this looks at, it's really just showing approximately a 15 to 20% decrease in those antibiotics since we initiated our stewardship pilot back there in 2014. The next slide, please. The other thing that we've really focused on here in terms of not just days of therapy, but also a lot of our initial efforts were pointed towards our ICUs. Our intensive care units are really drivers of a lot of our antibiotic use. So we've been able to pull in some measures of things that we're already looking at, right? So not only are we looking at ICU days of therapy, but we've been able to tie in some things like length of stay, mortality, and C. diff rates, which are listed here. Over those 3 years or so, we really haven't significantly impacted mortality, but we haven't made it worse. Our length of stay in our ICUs has gone down a little bit, and our C. diff rates, which are very low to start with, well under 1%, have really largely not been impacted either. Our ICU data, while the previous slide kind of showed whole hospital data in terms of about a 15% or so decrease in a lot of those drugs, if we look specifically at our ICU data, it's even a little larger than that. It's probably upwards of 20 or 25% decrease in a lot of these broad spectrum drugs. And we've been able to utilize not just that data, but the accompanying, no harm. We haven't seen an increase in mortality in our sickest patients when we're using shorter courses and less antibiotics in general. So we've been able to utilize this data to help drive medical staff.
Hello?
Craig? Craig, did we lose you?
I can hear you. This is Pam.
But I'm not hearing Craig.
No.
Okay. We will contact him real quick here.
Hello, is everybody still there? This is Craig Pleiman calling back in.
Oh, yes, thank you, Craig. Yeah, we were just trying to
All right.
contact you.
Yeah, my apologies. Our phone just cut out. So getting back to where we were there, so in terms of not just days of therapy that have been measured, but we also have moved towards some other stewardship metrics as well. Things that we've looked at in terms of reviewing our patients with C. diff, looking for opportunities for everything from antibiotic de-escalation to removal of proton pump inhibitors. We've done a lot of this. This identification really comes through microbiology in our infection prevention program. We also realized we have some problems with overtreatment of SSTIs with gram-negative drugs, so using Zosyn for one and for all. So overtreatment of SSTIs is something that we've looked at. In terms of SSTI, we've actually been able to generate some reporting functionality through our computer system by using indications for use that we've had physicians, that we require physicians to now indicate when they go to prescribe antibiotics. And in an ideal world, what we'd really like to look at, we've been pretty careful in how we've set up these measures because we don't want to set ourselves up to fail. Because initially, all of the sites, at least all 4 of our hospitals, which are widely varied, we all feel like at times we overutilize things like carbapenems. So at one point in time, we talked about just a simple measure around decreasing carbapenem use. And while that's good at its surface, when you think about how that would work, really what you want to do is decrease inappropriate carbapenem use, because we don't want to decrease carbapenem use in the appropriate patient. So again, that comes back to having baseline data of how much of your carbapenem use is appropriate in the first place, and then coming up with your own definitions in terms of how to define appropriateness. So we haven't quite gone down that road yet, but we're getting closer and closer to that. Those are going to require a little more data collection. We'll have to consistently review all patients to have an idea of what our outcomes are looking like there. Worst case scenario would be you end up with something like an ESBL outbreak at a LTAC down the road, and you inherit their patients. And then you have a lot of appropriate ESB or a lot of appropriate carbapenem use, but you get dinged for it. So just being careful on how you set up your own metrics in the first place is imperative. And that's where a lot of kind of that group conversation and running these through committees of physicians and pharmacists has been very helpful. So next slide, please. Actually, Chris is going to take over here. He can speak a little more to our antimicrobial use data submission to NHSN, so I want to hand it over to him for a little bit anyway.
Okay. In early 2016, Premier Health, the leadership decided to pursue submitting the AU data to NHSN. So we contracted, searched for consultants to help us do that, contracted a consultant in early 2016, and by the end of 2016, we had the antibiotic use data collection built. Next up was to take the data that was being abstracted. We tested it to make sure it was complete and looked valid. We submitted test data to CDC or NHSN, and from there we began our data reporting. And so we started off with third quarter 2016 antibiotic use data and have continued since then. So we're getting ready to submit our second quarter 2016 data to NHSN. And when we first started this effort, I know there weren't many hospitals that had submitted data at that point. I believe when we first started, there was about 15 or 20 hospitals that had submitted data out of 5,700 across the country. But I think last time I checked, in the last month or so, there's about 250 hospitals now submitting data to NHSN for the antibiotic use. Next slide, please.
You want me to speak to that?
Yeah.
Right. So this was with our first data submission, and this was when we were trying to figure out kind of the differences between what I had done kind of manually here in the past and what we were getting from NHSN. And really what this shows is our days of therapy number decreased at each of our 4 hospitals by somewhere between 10 and 20%. So our numerator was decreasing by a bit, but our denominator was increasing by 2 to 3 to 4-fold, depending on the hospital. And that really has to do with the way that NHSN's definition is set up for their 1,000 patient day calculation, specifically for this antimicrobial use module. And for patients that are transferred from one unit to another throughout a day, that will count as 2 different patient days with this new calculation. I had historically always utilized like patient days by midnight census because that was something we already had available to us and I didn't have to calculate it. So what happened overnight is our data, it looked like we decreased our days of therapy by 1,000 patient days by 2/3 across all 4 of our hospitals, even one of them by almost 3/4, just mainly based on the denominator changing. So we're actually kind of in the process now of creating new baseline data with NHSN by which to measure ourselves moving forward. Just kind of limitations of, you know, the different methodologies by which to calculate these patient days. So I think next slide, please.
So the quality department, one of our missions is to try to take the data that we're collecting and turn it into something that's easy to use and actionable. So what we've been doing since we've started submitting data is building out a reporting mechanism for it. And we have a product that allows us to take data from different sources. We can take the antibiotic use data that we get back from NHSN, and then we can put on the same scorecard as like length of stay and mortality and some other measures, whatever other measures that we'd like to look at. And the scorecard that's being shown, it has the AU, the standard, it's the antibiotic administration ratio that's provided by NHSN. So this was something new that we've not seen before. So we're still looking at it and evaluating it and trying to understand the meaning in terms of how we practice and use antibiotics. But it's something that we're out there, we're trending, and so the administration ratio, it's looking at the ICUs, the med-surg wards, and one specialty care area, which I think it's our burn unit. So that's what's rolled into our SAAR, our metric. The other one we're looking at is the days of therapy, which is, you know, similar to what had been collected before, but it's different in the way the days per resident is captured. So, you know, we're still working with those two indicators. And if you go to the next slide, please. The way our scorecard works is it enables us to drill down on different things. So, for example, our SAAR, we can look at a trend over time of all the data that we've submitted. And it gives us a drill down by unit. So we can look at the ratio across all the different units that we've submitted data. So NHSN is saying 1.0 is, I guess, their average across the data that they've collected. So we can compare our units against that. So it also allows us to do a lot of different data integrations. We can do regression analysis to see cause and effect over time of antibiotic administration versus length of stays and things like that. Right. Next slide, please.
Brilliant. I mean, I guess moving forward, we're continuing to work through our quality department. We're going to try to utilize data to extract some of our other measures that we're already looking at in terms of some of our C. diff reviews and in terms of some of our SSTI reviews as well. One thing that we found that very useful for is that it requires each of our 4 hospitals to document things in the same fashion so that the data is extracted in the same way, but it provides a lot more consistency across the 4 hospitals. And even within one hospital with 2 different pharmacists doing antimicrobial stewardship. So a little more consistent process. I would say involvement of your quality department is imperative. More and more of this is coming, so you may as well get on board now. I always say stewardship is probably where infection control was 15 or 20 years ago. We'll continue to see more and more mandates in terms of antimicrobial stewardship. And certainly it provides a standardized means for reporting your data, whatever it is that you determine you're going to measure, get it in front of your medical executives, step up and figure out something you can measure to be successful. So that's our brief summary anyway from Premier. I guess we'll probably turn it over to the next speaker.
Thank you so much, Chris and Craig. what we'll do is go ahead and have Pam go ahead and present from a small hospital viewpoint, and then we'll open it up to questions after that. Pam, if you want to go ahead.
Sure. So Union Hospital is located in rural Tuscarawas County, close to Canton, Ohio, for perspective. Prior to implementing our antibiotic stewardship program in 2013, we did have ID on staff. They had come on staff as consulting physicians in 2010. At the time, we had a VP of Medical Affairs who had previously been a pharmacist, then a surgeon, and was very interested in antibiotic stewardship and was really spearheading the project. So we started out by collecting baseline data and doing some other, just basically trying to look at our resistance patterns, and then we put some structure around the program. And if you can go to the next slide, please. So we started out by researching best practice guidelines for metric suggestions. Really, at the time, the CDC had some good guidelines out there, and the Infectious Disease Society of America also. We looked for some external benchmarking data because we're a small hospital, 154 beds in a single standalone community hospital. We wanted to be able to measure our performance against others. And as the previous speaker said, there isn't much available in that regard prior to the NSHN database. So we kind of abandoned that outlook and started trying to define our own internal benchmarks. And after we did that, of course, we had to see, well, this is what we would like to do, but can it be measured and collected, and is the data available? I worked with the IS department, data mined our hospital information system, which we use Meditech, and discovered that there was some fairly easy data collection that could be performed on a regular interval, although I have to confess that it's mostly manual tabulation in 2013 and still to this day. So just as the previous speakers mentioned, you do have to establish your baseline. We actually went back to 2009 in some cases and established where we were at that point so that we could have some baseline data for when our program was implemented in 2013. You need to assign responsibility to who's going to measure and the frequency of measurement. You monitor for your program effectiveness, pick what your outcomes, your desired outcomes are, and then report out and take action. So that's my summary of how to get started on the program if you've not yet started on this type of antibiotic stewardship program. Next slide, please. This is just a screenshot of what the National Quality Forum has. It's excellent. It wasn't available when we were starting. This was just published in 2016. And core element number 5 discusses tracking and monitoring your program. And that actually was what I was asked to talk about today, was how we, what we measure, how we measure, and how we report it out. So the next slides, we're going to discuss several different types of measurements that we perform here at Union. And the first one is an expenditure measure. This was actually recommended as in the guidelines, the IDSA guidelines. So they recommended that you measure your antibiotic costs as one measure of performance, and not just your purchasing data, but your administration data. So we actually are able to capture that through reporting out of Meditech. And we actually take that data and then do some manipulation of it, put it into Excel, and we measure that over time. So next slide, please. So this slide represents the expenditure metric, and what we look at is the percent of our total drug spend that is spent on the therapeutic classes of antibiotics, antifungal, and antiviral drugs. So in 2009, we went back and captured this data. We were not quite 18% of our drug budget was spent on that therapeutic class. And then we implemented our program fourth quarter 2013, and you can see a pretty significant decrease in our percent of total drug spend on those classes. And we've maintained a pretty good downward slope in that regard. Now, this is not at all leveled for inflation. So if we would take inflation out of there, we'd see a steeper decline. And so the data in the last data point represents through June, which is somewhere around low 7% of our budget, of our drug spend is now spent on those drug classes. Next slide. So a second expenditure metric that we tabulate and report out is our mean cost per adjusted patient day. So of those antibacteria, antifungal, and antiviral administrations, we divide that by adjusted patient day and come up with a number, and that is plotted on this graph. So when we first started out, we were about $9 per adjusted patient day, and right now we're below $5 per adjusted patient day from a financial standpoint. Next slide, please. So similar to the previous speaker, we were looking for some sort of a metric for the antibiotic use measure. So the CDC recommended two different types, and still does today, of quantitative measurement that you can use as a numerator. And the first one was days of therapy. The second one is defined daily dose. So days of therapy is a little bit difficult to get your hands around. And for the reasons mentioned by the previous speaker, we didn't have a real good way to get that data. And so we chose to do a defined daily dose measurement as an alternative. Next slide. So I think I've already talked about this. You can go on to the next slide, please. So in researching how to do the defined daily dose, the World Health Organization actually has a very good guideline. The web address is noted here on how to get that data. So essentially, a Rocephin dose, a defined daily dose of Rocephin is 2 grams. So you would tabulate your total gram utilization or 2 gram utilization divided by whatever denominator you're going to use to get defined daily dose per adjusted patient day, or whatever you choose to use. Next page. So essentially, I just copied this out of an Excel spreadsheet. We started tracking this in 2012. So equivalent 2 gram doses are started out in 2012 as 3,103. In 2017 to June, it's 1,227 divided by our adjusted patient days for acute patients. And through that, then go to the next page. We keep track of, pretty similar to the previous speaker, drugs. We use Excel to put it into graphic form, our defined daily dose per adjusted patient day times 1,000, just so we can get it on a graph and make it meaningful. But the graph I have is very busy because it has data from 2012 through 2017. So this is just a snapshot of a couple of years. So each drug has its own data point. Okay, next page, next slide, please. So we've been capturing that type of data for a number of years, and this year I wanted to look at something a little differently. Go to next slide. So I wanted to look at not only our financial expenditure per adjusted patient day, or targeted antibiotics defined as a defined daily dose divided by adjusted patient day for, I think it's 13 or 14 different antibiotics, but I also wanted to look at our orders and going down per adjusted patient day, and as our units, in other words, as a measurement of length of therapy going down per adjusted patient day. So this is just an opportunity to look at your own metrics. You don't have to use necessarily what the CDC says is the best. You can add to it if you think it's not giving you what you need to look at within your organization. Next slide. So from an outcome measure perspective, we look at new onset C. diff infection rates and reducing antibiotic resistance. I'm sure in your organizations as well, your ID physicians review your antibiograms. Next slide. And so this is just a representation of our C. diff isolate number from 2010 to 2017. and that's through June, as well as our Staph aureus identified as MRSA, and we've seen a significant reduction in both of those. Now, I'd like to say that antibiotic stewardship has a part in that, but I will say from a C. diff perspective, our quality department has really led a great initiative with our hospital nursing staff to reduce our number of C. diff infections. So however the outcome is obtained, we are seeing a significant reduction in both of those. Next slide. Just a graphic representation of both. It's always important to put graphs for your visual learner type people. Next slide. So then finally, benchmarking. We talked about this a little bit before. There are, you can attempt to find benchmarking through a purchase benchmarking service. We did subscribe to one of those that did have a measure for antibiotic utilization as a % of drug spend. So I was able to externally benchmark that. We do not use the SAAR, the CDC module. We looked at purchasing that, and it's for an organization our size, it was just cost prohibitive. But we have been able to get some good benchmarking data from our purchasing group. So we feed the purchasing group our data. They put that into a spreadsheet and spit out where you compare to your peers. Next slide. And then finally, as the previous speaker mentioned, that does go up through our Pharmacy and Therapeutics Committee. It does go to infection control, our medical staff. That is a report to our medical staff and our medical executive committee. I do put together a one-page dashboard that has been published on our medical staff portal. We are including that as part of our annual update for our nursing staff this year. And it is a report at Pharmacy and Therapeutics and Infection Control each quarter. Next slide. And I think that's it.
Thank you. And I appreciate both presentations. I think there's a lot of great information there. We do have already a couple questions, so I'll go ahead and open it up. Were you measuring only IV days of therapy, or also PO and IM doses? Craig, do you want to take that to start with?
So our data would be cumulative. So when we look at Levaquin, it's IV and PO days. And if we're looking at, we don't use a lot of IM antibiotics on the inpatient side, but certainly IM, ertapenem would be encompassed there as well. I know the NHSN modules, moving forward, you can break that down by any route. So TOB, IV TOB, IM TOB, inhaled tobramycin will all be, you can report that out individually or cumulatively. So yes, looking at all routes.
Okay. And just as a follow-up to that, when you report up through your system, do you separate those out, or do you just mostly discuss the cumulative effect of all days of therapy fighting?
So that kind of matters who we're presenting it to. So when we take our data back to the ID doctors, they like to see individual drugs. They like a little bit more minutia, but most of our executives just want to see kind of gross cumulative data. So it's presented in different fashions to different groups. For our ICU doctors, we tend to take our ICU specific data back to them. But for our medical executive committee, we just take whole hospital data to them.
Okay, thanks. Pam, anything additional you want to add to that question about measuring days of therapy?
No, we do define daily dose, and we do it all. It's all together. We do not include inhaled Toby in there. And because we're a small organization, our nursing leaders are all on the same committees. Our physician leaders are all on the same committees. So I prepare essentially one dashboard report and report the same information at, all meetings.
Okay, thank you. Second question is, Craig, what is status?
I think I'll let Chris answer that.
Okay.
It's actually a product from Midas that It's made for data integration and visualization so that you can take a number of different data sources and create scorecards and combine, do kind of like this data integration, combine different quality indicators on one scorecard. And it also allows you to drill down to patient level detail with that data. So,
sounds like a nice product.
Yeah, we're still working with it.
Perfect. Since, Craig and Chris, since you actually utilize the AU and SAAR from NHSN, because I know Pam said it was just more than they can handle in their small organization. What do you see the benefit in that information compared to what you were doing prior to that?
I would say that the best thing that we're going to get out of there will be comparator data, because right now, I mean, if we use Premier as an example, so you have large level 1 academic type medical center on one hand, and you have a small community hospital on the other, and it's really hard. I mean, intuitively, we shouldn't compare ourselves to each other, but we do. So really, all of our data really should be looked at just internally for trending purposes, but it's very easy for me to compare ourselves to a small community hospital. It's really not a like comparator. So the NHSN data will help us to get that data out from a national perspective to kind of show us where we are in the scope of benchmarking data is really the simple answer to that.
Okay, great. Pam, anything about, are you feeling that you're getting adequate comparison data through your other sources versus NHSN?
Ideally, I would like more robust external benchmarking, but it's sort of in the comparison of med errors. You really can't compare organization to organization. You define it differently. You serve different patient groups. I feel like I have a good handle on our performance internally. I occasionally get an inkling of our performance to other organizations externally through our purchasing group. I would love to be able to be part of a national benchmarking coalition, but right now it just isn't there. We looked at a couple of different methodologies to purchase to report up, but again, they're just at the time we looked at them, they were just cost prohibitive.
Okay, great, thanks. Next question is, looking at the data, because both of you are collecting various data in different formats, including financial as well as the actual days of therapy or daily doses. But to you, what do you find when you're working with your medical staff and your clinical leadership the most meaningful stat? Because as many of our hospitals in both states are just beginning to really look at starting collecting metrics, where would you have them start, and then how would they proceed in expanding their data collection?
Well, for me, I think first of all, you really have to define some sort of financial metric, because you're going to ask for resources for this project. We do pay our ID docs to be part of antibiotic stewardship, and we did have to add a half an FTE of a pharmacist to work on this project, and we had to develop an IT solution that allowed us to communicate from a dashboard perspective with our ID docs so that they can review notes that the ID pharmacist is sending back and forth and look at patient charts and cultures easily without filtering through, every patient every day. So I think you have to have some sort of financial metric that shows some sort of a positive outcome to justify your program. And then secondly, any kind of use measure that shows something, either days of therapy or defined daily dose that can show that your program is effective. That's just my opinion.
Right. I think I would agree with that wholeheartedly. And again, it kind of matters who you're presenting the data to. You don't want to guarantee a certain financial. It gets a little bit tricky because after a while you do reach points of diminishing returns. So we've been a little bit careful in not holding our physicians accountable to a decrease in spend. We've certainly seen lots of decreases in spend as you decrease antibiotic use by 20%. The cost savings follows. As an example here, our healthcare system made a huge change in just our IV fluid contract. So as a healthcare system, we went to B-Braun, which across the system saved, I don't know, several $1 million. But at the same time, it actually increased the cost of some of our antibiotics. So some things like good old-fashioned Ancef actually went up in cost. So our antibiotic spend for some of those drugs went the wrong direction, even though our days of therapy really stayed the same. So you always have to be a little careful with the financial end of things. I would tell you, if you're measuring some sort of antimicrobial use measure, as long as you're decreasing antimicrobial use, the spend will follow. And certainly, administrators like to see the dollar signs.
Yeah, don't we all?
It does get tricky with the financial piece of it too, because it's not always a level playing field. You can get an expense change out of right field. The drug is now in short supply. You have to buy a more expensive product. And I will say that I did have a surveyor ask me about our financial performance where we seem to level off. Well, why aren't you still decreasing? Well, you do get a point of diminishing returns, which is why I added the additional internal benchmarking data. You know, I want to see now our orders for antibiotics decreasing, and if they're not, you know, if we've reached the point of diminishing returns where we think that most of our initial orders are appropriate, then our units or our days of therapy of a particular order being decreased. So think outside the box.
Okay. Just as a further clarification, so for both of you, are you finding that the data that you have, you can access through your pharmacy systems, or do you combine that with other systems within your organization to come up with these reports?
At least here at Premier, we're utilizing a variety of functionalities, and some of it is still tabulated manually. We're moving towards more and more automation and third-party software to extract a lot of the data from to help us extract things from our medical record in different databases. But a lot of it still is manually collected at this point as well.
The data that I'm utilizing is out of our hospital information system, primarily the pharmacy module. I do have to rely on the lab for the microdata.
Okay. Yeah, I just want to make sure that we gave everyone ideas where to get the data. I'm not currently seeing any additional questions. Do either of you have any additional comments that you want to make before we close the meeting?
No.
Nope.
If not, yeah, I want to thank all three of you. It was very informative and really gave us a better idea of what potentially you can collect. And would you be willing to be a resource if someone has additional questions after the session?
Yeah, that's
sure.
Fine with me. Yeah, sure.
Okay.
Yes.
Thank you, and I really want to thank everyone for attending. Again, just as a reminder, both nursing and pharmacy credits are provided for this session, but to do that, you need to make sure you complete your evaluation online on the SurveyMonkey, and the link is in the session. And just as a reminder, the copies for the second set of copies of the slides for Union Hospital will be sent out later this week. They just we're not 508 compliant, so we couldn't send those out, but we will get those out to everybody later on this week. And if anyone continues to have questions, feel free to let us know, and we will make sure we refer them to the appropriate person. I want to thank everyone for attending, and our next month will be November 8th. November 8th, and the 14th, and the session will be really addressing specific interventions for antibiotic stewardship. So stay tuned, and we will talk to you next month. Take care. Thank you again.